Well, good morning, everyone. Certainly was a truly inspiring discussion and talk, and will be a challenge to follow, but this will be a bit more focused on a specific topic and looking at drug-coated balloon therapies. Our infrainguinal interventions, similar to what we've seen in coronary and other vascular beds, have been limited by animal hyperplasia. Animal hyperplasia results from stimulation in the form of angioplasty or stent placement to atherectomy, results in migration of smooth muscle cells, proliferation of those cells within the subintimal layer, and the elaboration of extracellular matrix proteins resulting in restenosis. This has been well studied. The efforts to intervene in these areas are designed to try to limit the proliferation of these smooth muscle cells. And there are really two main categories. Within the coronary circulation, as most people know, the rapamycin derivatives are cytostatic, and they're eluted over time from a polymer on a coronary stent. In the infrainguinal femoral popliteal distribution, it's paclitaxel derivatives, which are actually cytotoxic and have a different mechanism of action and are delivered in a single initial dose. Drug-coated balloons are really multiple components. There's the platform itself, which is the balloon. There's the paclitaxel, which is the agent that's responsible for the cytotoxic activity. And then there's the excipient that transfers the paclitaxel from the balloon through the aqueous environment into the vessel wall. If we look at the randomized controlled trials, they're similar in their design. Predominantly patients with claudication are included. They meet the anatomic and physiologic inclusion and exclusion criteria. And then they undergo pre-dilatation. And it's only after this successful pre-dilatation, in other words, you do a pre-dilatation with a 1 millimeter undersized balloon. If there are no flow-limiting dissections, no flow-limiting recoil, the patient can then be randomized to either angioplasty with a standard angioplasty balloon or angioplasty with a drug-coated balloon, and typically these are done in a 2-to-1 ratio, so there are twice as many patients in the treatment arm once randomization has been completed. The randomized controlled trials are fairly similar. They're treating what I would call moderate length lesions, about 9 centimeters in the IMPACT trial, and I'll go through the 2 other trials as well. When we look at provisional stenting within these trials, it's quite limited. Again, I think as a result of trial design, you couldn't really be randomized until you had no flow-limiting lesions, so provisional stenting in 10% or a little bit less perhaps. And really dramatic results were identified in all 3 of the trials I'm just going to touch on. First, in the IMPACT trial, you see out now to 3 years, looking at primary patency, there's been a sustained improvement in primary patency in the treatment arm. So in this table, this life table analysis, you'll see the red graph or red line represents the treatment arm, the IMPACT paclitaxel-coated balloon-treated arm of the study. And out of 3 years, almost 70% sustained primary patency. When you look at the control arm, the angioplasty-only arm, about 45% at 3 years, which maybe is a little better than what had been reported historically, but again, a dramatic absolute difference and certainly a dramatic relative difference and highly statistically significant improvement. As a result of that, there is an observed decrease in the need for target lesion revascularization. Freedom from target lesion revascularization was 84% in the treatment arm, 70% in the angioplasty alone arm, and again, highly statistically significant difference between those 2 cohorts. There are several groups that through the years have been identified as being challenging for these minimally invasive endovascular procedures, particularly angioplasty and stent placement, but also atherectomy to a degree. Women have not always fared as well with these interventions, but did quite well and had a very appreciable response to use of paclitaxel-coated balloons. And patients with diabetes also had a very favorable and statistically significant improvement in their response in terms of sustained primary patency. The purpose of these interventions obviously is to improve claudication in these patients, and this was observed in the IMPACT trial with sustained improvement without the need for reintervention based on 6-minute walking test and walking improvement questionnaires. Lutonix has a similar trial and a similar formulation. It's, again, paclitaxel, a slightly lower concentration, a different carrier, but quite similar in overall design. The randomization scheme, similar as well, a 2-to-1 randomization scheme, and again, after successful pre-dilatation. And again, demonstrated a statistically significant, this is at 12 months, statistically significant improvement in primary patency. Not the same absolute level of improvement, but nevertheless an identifiable improvement. Was not significant enough to result in improvement in target lesion revascularization in this particular trial. But they did demonstrate sustained improvement in the clinical endpoints in terms of walking distance and walking impairment questionnaires. Finally, StellarX has recently reported their results both in their European trial and in the pivotal trial here in the United States, using polyethylene glycol as their excipient and paclitaxel at that 2 microgram concentration. 2 papers have been published reporting the results of both the European and the American trials, and you'll see that our host for today's session, Dr. Krishnan, was the principal investigator, so wouldn't think to lecture him on the results of his own trial, but they were quite successful. This just depicts both the pivotal trial on the lower panel and the European trial on the upper panel, both showing sustained benefits in primary patency, and similar results in the 2 trials are reported. The European trial now has reported their results out to 2 years, and again showing sustained, statistically significant improvement in primary patency with the treatment arm, the paclitaxel arm of the trial, and again resulting in freedom from target lesion revascularization. So there does appear to be a class effect. Paclitaxel does appear to be successful in preventing restenosis and maintaining primary patency. So restenosis certainly has been a limitation. It remains one for us, but there's now level 1 evidence that demonstrates that paclitaxel can improve primary patency and reduce the need for target lesion revascularization. And we'll have to see as these technologies and techniques are applied in clinical circumstances outside of these randomized controlled trials, what the clinical impact will be for us in our practices. Thank you very much.